Pleasure to introduce Dr. Ruben Mesa. Dr. Ruben Mesa is the President and Executive Director of Atrium Health Wake Forest Baptist Comprehensive Cancer Center and Professor and Vice Dean of Cancer Programs at Wake Forest University School of Medicine and Cancer Center. And Dr. Mesa will be talking about MPN patient symptoms and how to address them. Thank you, Ruben.
Well, how is everyone doing today? Wonderful. Well, I have to share the thoughts from Ron that meetings like this really owe their origin to Dr. Silver. Going back in the late 1990s, it was both strong patient advocates, folks like Joyce Niblack and many others, as well as physicians like Harriet Gilbert, Dick Silver, and others that had the idea in the late 90s of bringing physicians and patients together outside of a clinical venue, outside of the exam room as a group. This was heresy. Physicians were terrified. Like, oh my gosh, they can ask us anything they want, as a group. What if I don't know the answer? Patients could get together, meet other individuals that are suffering from similar things or have similar questions, or the feeling that they're not alone as they're facing a disease. So it was a really, really innovative thought. And no one has been a stronger proponent than Dr. Silver, his colleagues, and what a tremendous successor in Ghaith. Now, this topic is early on, and it's very much evolved over time. In the past, medicine used to think, well, you've got hardcore science, which means there's a mouse. If there's not a mouse involved, it's not science. If there's no one pipetting, there's no mouse, that's not science. We could have 1,000 patients, forget that. But if you've got 3 mice, that's science. Or you have this other bucket of kind of soft, feel-good, kind of squishy science, how are you feeling sort of stuff. What we've learned over time is that these two things are really much, much more related than we might imagine. Now, it's taken us a little bit of time to get here for a couple reasons. One, medicine overall has been very geared to dealing with the hyperacute. You have chest pain, you go into an ER, they're racing around to see how quickly they can open up an artery. Very, very acute-minded. Hospital beds, ICUs, acute, which is all very necessary. And it struggled much more with how do we deal with chronic? How do we deal with diseases that we can't cure, but we really try to make a difference against? Even here as a cancer center, and I lead a different cancer center, again, realize that the C word brings up a lot of emotions. But it's a really, really heterogeneous group of things. It's things that are really chronic, that may or may not shorten your life, but they can clearly impact you, to things that, again, that are very, very hyperacute. So I raise all of this because issues of how one feels, what that tells us about the biology of the disease, how that relates to therapies, really is an important intersection between these two things because it's a chronic disease, which is very different than sometimes how we approach other diseases. Historically, again, someone has Hodgkin's disease. There's a very specific way we treat that. There's ups and downs in terms of side effects that people endure. We clearly want to try to diminish those, but as a way to try to cure that frequently curable disease. People say, well, I'll put up with whatever for these next 4 months. I'll batten down the hatches. My sister will come over. My friends will make meals. I'll get through it. This is a very different thing. How do we understand the symptoms that MPNs give us? How do we particularly take a little deeper dive around fatigue, which is the most common symptom? And how do we try to have the disease be as invisible in your life as possible? Part of that is medical. Part of that is psychological. How do I frame this? Part of it is what else can I do? Diet, exercise, sleep, other sorts of pieces. So here are my disclosures. I've been involved with most of the trials that have on in the MPNs. So first, what is fatigue? If I ask everyone in here, I'm going to get a whole bunch of different answers. Perhaps the way to think about this is pathologic fatigue. What is fatigue really related with an illness? We do know that in life, we get tired. It's just a natural part of the cycle. Whether it's a full day at work or a fun activity, going to a wedding or, the people that ran in the New York Marathon. We can get tired. Now, fatigue, in my eyes, is something slightly different. Is beyond the normal cycle of tiredness, but it's a different feel. If someone has, let's say, the flu, they wake up and they feel lousy, but in a way that is different than normal life. Now, when we studied fatigue, we realized that again, in the general population, everyone has some degree of fatigue if you ask them. Like, boy, I have all these things. My kids are in traveling sports. I have to travel here. I have to travel there. Or sometimes tough things. My wife lost her father to illness earlier this year, and saw everything that she went through with that, and that was brutal. And that caused a tremendous amount of fatigue. Now, she didn't have an illness, but clearly there is a burden to life that can translate into parts of fatigue. So when we realize that the ground is not at zero, we think about pathologic fever. Normally, we're not having pathologic fever, so that ground is typically zero for most folks. But fatigue probably a little bit higher because of all of the elements related with life. But MPNs, because of their effect on the bone marrow, as well as things that they do in the bloodstream, can directly cause fatigue, a pathologic fatigue, that's been validated across, patients, languages, cultures, as a uniform concept. Now, how did we get started on asking this question? Well, it really came from patients, from meetings like this, where Joyce Niblak came to me after one of these meetings back in 2001. And she's like, Ruben, we feel lousy. We frequently feel because we're the healthiest looking person in the oncologist waiting room that we are ignored, that we don't seem as sick. And the truth is, yes, that is correct. If you're in a waiting room with someone that has an advanced esophageal cancer and someone that's got advanced ovarian cancer, are you less ill than them? Possibly, yes. I would argue that it really doesn't matter. One, it's not a competition. And two, it's just a very, very different set of things. It still doesn't negate what you're feeling. So she asked, she's like, well, how do we tell this story? Well, I'm like, well, there are ways of us trying to quantify the subjective. How do we do surveys in a scientific way to really try to quantify some of these symptoms? And again, physicians that were involved with caring for these patients clearly were hearing these things. So this is back in 2007, where, again, we did an online survey through the online listserv. Some of you have participated in those. The online communities have evolved a lot over time as the internet's evolved. But it was a very powerful platform for being able to connect with folks, around the world. And it was very clear, no matter how we asked the question, no matter what language we use, fatigue was the number one symptom, ETPV-MF, without question. So what about the symptoms? So as we asked about symptoms, we got a whole range of answers, but several things reproducibly would continue to come up. Fatigue was clearly number one, but things that were related to enlargement of the spleen, if the spleen was enlarged, or night sweats, itching, sometimes things related that the blood wasn't flowing right, such as headaches, migraines, sometimes erythromelalgia, kind of painful areas, redness in the skin. There were sometimes things that were more idiosyncratic that one individual might have that isn't common, but there were several that really kind of surfaced to the top. Now, as we tried to estimate symptoms, we also tried to get a little bit of a sense of quality of life. Now, quality of life is a different construct. Sometimes people put both of these things in the same bucket. They really are not. Quality of life is broad. I'll use that example again. My wife had a terrible quality of life because her father was dying. This was not directly related to her health, but it clearly impacted her quality of life. Health-related quality of life are those things really related to an individual's health that can include direct symptoms from a disease, but it can be worse. It can be the hassle of medical care. Again, we drove here from the Brooklyn Marriott. Again, if one wants a poor quality of life, take that drive. Some of us thought we could have swam up the East River and that probably would have been faster. That hassle also can contribute to your health-related quality of life if you're going in once a week to get a transfusion of blood, for example. Or let's say you have significant financial toxicity. Boy, I can buy this drug, but because of it, I can't help my daughter, pay for her school because of it. Or, I'm having problems with food insecurity because of my medical bills. That can dramatically impact the health-related quality of life. Now, we worked with many of the colleagues in this room and really around the world to develop a series of patient-reported outcome forms known as the MPN symptom assessment form or the myelofibrosis symptom assessment form to have questions to try to quantify these symptoms in a way that was relatively consistent, so that if we did something that had an impact and changed a symptom, we could measure that. And we did this in part because when we started the clinical trials with the JAK inhibitors, people felt quite a bit better. And we needed to have some way to measure that. So with that, we've created these questionnaires. Some of you undoubtedly have filled some of these out. Over the years, there are several questionnaires, although they're largely interchangeable. They're now available in most languages. They're fairly consistent across languages and cultures. There are some cultural differences in terms of how severe you might say your individual symptoms are. But very interestingly, the ranking of symptoms by disease is incredibly well preserved around the world. So fatigue is number one, whether it's someone in sub-Saharan Africa, South America, or Japan. Now, there may be cultural impacts in terms of whether people say it's a 3, a 5, or a 7, but the ranking is remarkably similar. And again, one can even fill it out in a way, and again, depending upon language, it may be right to left or it may be left to right, to be able to track these symptoms over time. Now, one of the early lessons that we helped identify is all MPN patients have the potential to have symptoms. Not all do, but ET, PV, and MF patients can have symptoms. Overall, MF patients have the most symptoms, but that is not universal. There are certain ET patients that have more symptoms than other patients with MF. So having an MPN, you may have symptoms, and again, MF being most common. Now, we also found that these symptoms are not necessarily independent of one another. They are kind of profiles in the disease, where the disease is affecting people in different ways, where people can have certain symptoms that kind of track together. So we did statistical analysis looking around clusters. And this would work with one of my mentees, Holly Geyer. We were able to show clusters of how symptoms may distribute between ET, PV, and MF. And you see there these lines, red is more symptoms, blue less. Each line top to bottom is an individual patient. So this is data about 2,000 patients kind of on one slide as a heat map. And you see that there are clusters of the most symptomatic individuals by disease. And over time, we studied these to try to learn more about what that tells us regarding the biology of the disease. So what is the link between biology? So when we started this work, there was the thought from the reviewers. So for those not in the medical world, the reviewers are you could think the most cantankerous IRS agent type folks. They get your manuscript, they break out the red pen, and starting with the title, boy, they got thoughts, some of them helpful, sometimes not, and when we first did some of this work, we had reviewers say, I don't know if I buy this. Yeah, you've got 2,000 patients who said they were symptomatic. I've seen 2 people in my clinic, and in these 6 minutes I allotted each of them for their visits, they did not really go in depth into their symptoms. They seemed to be much more concerned about their blood counts. Now, part of their critiques were, well, is this all in their heads? Is this psychological? Is it due to the anxiety of having a disease that folks don't necessarily know? It's not discussed on The View. It's not in the public awareness. I think there's a little bit of both, what we have learned over time. One, there clearly is a biological driven process with inflammation, with other mechanical aspects of the disease, with impact on circulation that clearly can contribute to symptoms related to the disease. 2, the potential of both mood disorders and reaction to having an atypical illness, an illness people really can't relate to, is a factor. And that both of these things matter. And like any things that we react to, sometimes that reaction can take on a life of its own and needs its own therapy. Are there patients that have had depression from being diagnosed with a chronic disease? 100%. So we've learned that that is real over time, so that isn't ignored, because sometimes that needs to be addressed just as any other illness can be addressed. But we did help to validate it in the studies, here red is bad, green is normal, that as we looked at different markers of inflammation in the bloodstream, that they were indeed increased. And this was in patients with myelofibrosis, so it's a select group of people that are more symptomatic. We've been able to tease apart over time how these symptoms occur, how they tie to biology, and to give us more insight into both if we have therapies and they improve symptoms, how do they improve symptoms? And 2, how might we make a better impact over time? We've learned these proteins in the blood called cytokines, chemokines, inflammatory markers. They have different aspects, and some may relate with everything from progression to other aspects. So, for example, pathologic weight loss. When we have a patient who's otherwise stable, they're on a stable dose of medicine, they start losing weight without trying. 1, the reaction is usually the same. Thank God I'm losing weight. Doesn't matter the cause. It's its own fascinating statement. No one loses weight in our society without trying. In fact, most of us try and still don't lose weight. So that's usually a sign that something is off. Now, that could be depression, but that in this context of this disease, clearly could be an issue of progression. Now, as it relates to fatigue, there's another fantastic patient advocate, Zen Senyak, again, who was a fixture at this event for many years, wonderful guy. And like Joyce, these are individuals like Dr. Silver who really change the world around them. They're pushing, they're asking questions, they're driving change. And Zen said, I'm really worried that this depression issue is a real thing. Let's help to quantify it. So we worked together, again, with other patients, designing a series of surveys to really try to delve into this. This was an additional 1,800 patients. And what we identified using screens for mood-related disorders is that, yes, MPN patients had a higher rate of anxiety, depression, stress related to their disease. Not universal by any means, but it could both be a real thing as well as something for physicians really to be mindful of. And then we were able to then tie that in with a variety of different connections and just bring that up for awareness, both for physicians and patients to keep that in mind. And as we talk about some of the strategies for improving fatigue, that relates as well. Now, we've learned some key lessons over time. 1, the longer one has a disease, typically the longer the symptoms may grow over time, not dramatically, but that is a potential. 2, gender can have an impact. There's no question. And if folks want to ask whether being postmenopausal can add to symptoms, oh, hell yeah. There's no question that menopausal symptoms clearly can increase menopausal symptoms. And I have gotten many of the lecture from my wife who has gone through this process to be especially sensitive to this piece as well. That again, there are many things that really can contribute, and there are both numbers behind this, but really also biology as well. We have found that insomnia is a close tie, without question. There's a lot of insomnia in the US, undiagnosed sleep apnea, restless leg, other aspects. If an individual is having significant issues with insomnia, it's very difficult to get them to feel better no matter what we do. So again, mindful of common things being common that really can add to the difficult symptoms. Now, we have also found that there is a profound impact on intimacy. And indeed, around the world, if fatigue is number one, number two are issues related to intimacy with MPN patients. Now, in many ways, this is an aggregate of many things. Is this things that are mechanical, such as impotence and other things? It can be. But it can be broader. Again, if you're not feeling well, typically the first thing that goes out the window is intimacy in your life, however you define that, realizing that there's absolutely nothing more personal between an individual and their partner than this concept. But if you're not feeling well, if you have night sweats, if you are fatigued, if you're having an uncontrolled headache, this is a major barrier. On the flip side, when this is more in line with wherever that individual thinks that it should be, that also is a very good litmus test of, again, reasonable quality of life. Because quality of life fundamentally is a delta between where you are and where you think you should be in terms of how you are feeling. Now, what about fatigue and symptoms as a goal of treatment for MPNs, or how we monitor it in trials? One, we know that it's had an impact on a range of things. One, it can clearly impact working, employment, activities of daily living, as well as things that we enjoy. There are individuals that have cut back on their work schedule, are medically disabled, or again, decide to skip events that they otherwise would go to. The answer is yes. And on the flip side, part of our goal is, again, to try to have the disease be as invisible in your life as possible. So again, in the approach that you have to your therapy with your treating team, how close are you to living your life the way that you desire that you should be living it? When we measure symptoms, each individual patient is really their own control. So although we can give a number to it, let's say I have itching and I say it's 4, and let's say Ghaith says that his is a 6. The difference between us doesn't matter. However, if we both went on a therapy, because my 4 may bug me more than his 6. But what is consistent is that if you decrease those numbers by half for each of us, that is relatively consistent and reproducible across individuals. So everyone is really kind of their own control as opposed to absolute numbers. And with this, we've used this in many different clinical trials around the world and are able to somewhat compare across studies. Now, there were those at the beginning who questioned, well, I have symptoms, as someone that doesn't have a disease. Show me that having an MPN is different. So working with colleagues in Ireland, they did exactly that study where they took age-matched controls, and they found overall that each individual symptoms compared to ET and PV patients were able to show a clear statistical difference between the general public and patients with MPNs. And the important part, going back to the issue of fatigue, is that including fatigue. However, the baseline for individuals in the general public is clearly higher. So their baseline is higher, but the MPN patients were that much higher still. We were able to show that in terms of impact on quality of life, the two major things that had the most independent statistical impact on quality of life for MPN patients were both symptoms and depression. Either one having the greatest individual impact. Now, these things are used in clinical trials. This as an example of the final phase 3 that helped lead to the approval of momelotinib for patients with myelofibrosis, where symptoms were the goal of the study with additional benefits in spleen and symptoms. And compared to the comparator of danazol, we're able to show that patients overall felt better. And this is important because in the end, a therapy really fundamentally can do one of two things. It can help people live better, it can help people live longer, or it can do both. Everything else is a surrogate for one of those two things. So the FDA has very much evolved, including the EMA in Europe, to say, prove to us that it did one or both of those things. And clearly, a disease that is a therapy that's a cure, you have strep throat, you get cured, you clearly live longer than if you didn't have strep throat. People have died from strep throat in the past. So clearly is one or both of those things. And the chronic illness, sometimes showing people living longer, is a more complex and longer term analysis to do. And now we look at the improvement in symptoms in conjunction, not instead of other ways of measuring the impact of a therapy, but really in addition. You heard from Dr. Hoffman all those wonderful new therapies being developed. Again, you can imagine, we look at the portfolio of how do they impact individuals. Are their blood counts better? Is the spleen smaller? Are they less likely to progress? Do they feel better? Are there side effects from the therapy that may negate why we used it to begin with? So improvements in spleen, improvements in anemia. Likewise, just another therapy just to show you, this is routinely how we discuss these amongst ourselves in the medical community and how we compare them. Improvements in spleen with a use of 2 drugs versus 1 drug. This is a ruxolitinib along with pelabresib. Improvements in symptoms, the incremental part in blue. So improvement in symptoms, the delta perhaps more modest, but still an overall impressive decrease in symptoms. And then we look at individual symptoms, and then we look even from a Venn diagram sort of perspective, how these things kind of come together. We looked with that particular trial, as you see difference in symptoms, individual symptoms between 1 drug versus 2 drug. Again, as we think about fatigue, we almost realize, again, there's a different, fatigue is almost its own lane. Because it's not infrequent that we've had patients that have been on a therapy, everything is better, but they're still feeling fatigued. And that might be 1, because our therapies still are incomplete. They help, but they're not complete in terms of their benefit. And 2, there could be other contributors as well. Another drug in this space that's having an impact on fatigue that's investigational. Again, many drugs in investigation is a drug called nuvasertib that, again, is hitting one of these additional kinases. This is a global trial, improvement in symptoms, and they've been able to dig into the individual cytokines that are helping to improve these symptoms. And these slides, I'll share them. Chad and Ghaith will have them available. If folks would like a copy, certainly are welcome to have any of these. All of these are things in the public domain. And these symptoms then fit into how we decide on therapies. So as we get to trial endpoints for these diseases, again, we're looking at, do patients live longer? Do they live better? And again, we try to look at all of these things in aggregate, not necessarily one at a time. So final thing before concluding. How else might we combat fatigue? There's not a patient who comes in my office who says, well, what else? What else can I do? And as a physician now for over 30 years, I have long learned that there is a limited power to the prescription pad. One, they don't have prescription pads anymore. You can't find them anymore. They only be through the computer. So the dirty little secret is we really rely on our nurses to prescribe stuff because none of us can figure out how to send, drug X to the CVS that's over on 68th. Who knows? Some magic occurs, the drug shows up there. But what else can we do? Because it clearly can go beyond medicine. Well, one, I've had a chance to work with some really impassioned individuals that ask these questions. And this was a survey done by a wonderful colleague and mentee, Christina Gowan, who now leads integrative medicine for City of Hope, and did a questionnaire of MPN patients, again, trying to figure out how you as a community are really trying to have an impact on your individual symptoms. And what we found is that folks are really proactive. Again, large numbers of patients here, but physical activity, massage, yoga, nutrition, acupuncture, meditation, people doing a whole range of different things. What works? I think for any one individual, any one of these things might be helpful. Now, it's not lost on us that, one, there are some folks that already have tapped into these sort of tools in the past and kind of know how to use them and have access to them. Two, there's another group of individuals that really have never had access to these things, financially, time-wise, or experience. So we're mindful of, again, how do we help to empower individuals that are already inclined to do things that may aid how they feel in terms of nutrition, exercise, or others. And then a separate piece, how do we help individuals that really are completely new to doing anything else, to try to improve this. So we did a study with a yoga study with, again, colleagues from Arizona State University, where we had developed an online training course for yoga for people that had never done it before, that were specifically with some modifications for MPNs, less abdominal pressure for the spleen and other things. And these things were really quite positive. And again, more work continues in that regard. Finally, we have an ongoing study at the moment. Some of you may have been participating in this, really around the issue of meditation and sleep. Again, the power of restorative sleep is powerful, and the absence of such, it's difficult to overcome. We find that many of these additional approaches in integrative medicine, massage, yoga, acupuncture, their final common pathway is really better sleep. People sleep better, they feel better. So this study is ongoing, trying to see if we can, using meditation as really both a stress relieving device as well as a way to assist in individuals sleeping, can be impactful, and measuring inflammatory cytokines and other pieces with this. So I'll share that MPN fatigue is prevalent. It's a key driver of quality of life for MPN patients. This is tied to biology of the disease, and it is distinct from the normal fatigue of day-to-day living. It can be measured, it can be impacted by therapy, and it can have many contributors. It's a nuanced goal of therapy. Non-pharmacologic approaches are important, and certainly can aid MPN-related fatigue. And clearly, thinking everything that I've shown you is really collaborative work that really has originated and really been done in collaboration with yourselves and many patients, patient advocates, caregivers, and colleagues in the MPN world that have felt passionate about how else can we try to help people feel better. Fundamentally, that's why we have meetings like this, because we've realized another approach is education. How do we help to demystify, ask questions, decrease anxiety in any way that we can, including things like today, the question and answer sessions that we'll have this afternoon, and the breakout sessions. So with that, I'll hand it back to our Master of Ceremonies, and I know we have a kind of a panel session for questions later. Thank you.